speaker. Our speaker today is pharmacist Obo Ita. I find it strange just to call him pharmacist Obo Ita because he's a whole lot more than a pharmacist. He's a lecturer. Oh, please, may I just lay some ground rules? Can we all please mute our mics so that we don't have any interference? Please, I beg of you. Thank you very much. Thank you very much. And thank you all for coming in early. Our speaker today is a lecturer and a research fellow, Department of Pharmaceutics and Pharmaceutical Technology, Faculty of Pharmacy, University of Calabar. He is also a part-time lecturer at the Cross River State School of Health Technology, Calabar. I said he's more than a pharmacist. He's an associate consultant, Statistical Consulting Center, Institute of Department Research. Please, can we all mute our mics, please? Can we mute our mics? Thank you. Thank you. He's a research associate. I'm sorry, was I muted?
Yes, you are. Yeah.
I was muted throughout?
No, just along the line. We're going to continue now, please.
Okay, because I noticed I think the host muted me.
Yeah, because
but, sorry, because we have to know our speaker is.
Yeah, continue. You're a co-host. If you are muted on mute, you're a co-host. Yeah.
Yes.
Hello. You're
okay,
a co-host.
so.
Yeah.
So where did you lose me?
When you were introducing the speaker, please. You can start over again from that.
Okay, so let me run through his just 1 minute to run through again.
Yeah, please do.
Our speaker again, like I said, is pharmacist Obo Ita, and like I said, he's much more than a pharmacist. He's much more than a pharmacist. He's a lecturer, research fellow, Department of Pharmaceutics and Pharmaceutical Technology, Faculty of Pharmacy, University of Calabar. He's also a part-time lecturer at the Cross River State School of Health Technology, Calabar as well. He's an associate consultant, Statistical Consulting Center, Institute of Development Research. He's a research associate, International Society of Substance Use Professionals, research associate, International Society of Pharmacoeconomics and Outcomes Research. He's a member of CPAN. He's a certified data analyst. He's a member of the Red Cross Society, and he's also a member of the International Web Association, IWA. Please welcome with me to take us through this fantastic lecture tonight, pharmacist Obo Ita. Thank you very much, sir. Thank you very much.
Good evening, everybody. Please, am I being heard?
Yes, you are, sir. You're being heard, sir.
Okay. Thank you very much, the moderator. Good evening, everybody, and thank you for giving me the opportunity to present this, make this presentation. Please, the moderator, please, am I the one that is going to share my screen, or the technical team will do that?
Please share your screen, sir. You can
Okay, I should
your
share my screen. Okay.
Yes, yes. Please go ahead and share your screen.
Okay. Okay, our topic this evening, as we have heard from the moderator, is maintaining health during androgen deprivation therapy in prostate cancer. I want to thank Clinical Oncology Specialty Group and also Prostate Cancer Foundation for supplying us giving us the necessary materials for this presentation. As pharmacists, either we are in the industry, or we are in the clinical setting, or we are in academia, or we are in the hospital setting, something holds us together, and that is the provision of pharmaceutical care. And it was very, very timely when on February 4th, 2022, the world stood still when the cancer community worldwide celebrated the World Cancer Day with the theme, Close the Care Gap. You will agree with me, in cancer therapy, in cancer prevention, in cancer research, in cancer diagnosis, there's actually a care gap. So as pharmacists, irrespective of where we are practicing, how can we close the care gap? That is why we are looking at this topic, maintaining health in androgen deprivation therapy, because irrespective of where we are working, we have something we are going to contribute so as to close that care gap. So, what is ADT, androgen deprivation therapy, as used in cancer treatment, especially prostate cancer treatment? Before we go into this presentation, there's something I want us to understand. As we try to maintain health during androgen deprivation therapy, in other words, we are trying to improve the quality of life of these patients. So, stop for a moment. Think, the last time you were with a cancer patient, a prostate cancer patient, were you able to close the care gap? At the point of dispensing his medication, were you able to discuss with the patient, explain to the person certain things he or she can, certain things he can do to improve his quality of life? If you're in academia and you're into research, when last did you go into research about ADT? If you're in the hospital, if you're in the community, when last did you try to close that care gap? So, as I was saying, what is ADT? ADT encompasses therapies that are used in the treatment of advanced prostate cancer and targeted at depriving the bodies of androgens. What is the intention? The intention is to cause androgen deficiency in the body. ADT decreases serum testosterone level. Ideally, normally, the normal value is between 300 to 1,200 ng per dl. But ADT decreases that level to less than 200.
Sorry,
Yeah.
sir, just a minute. Your slide is not moving.
Okay, yeah. It's not moving because I've not moved it.
Okay, all right. Thank you. I just wanted to be sure. Sorry
Okay.
about that.
Okay. So ADT reduces that level to less than 20 ng per year. As scientists, by now, we've started thinking, when androgen is reduced to this level, what will be the consequences? How do we achieve ADT? By the what? Androgen deprivation therapy. That means we are trying to deprive the body of the sex hormone androgen. We can either use drugs or by surgery. We have the gonadotropin releasing hormone antagonists or agonists that are being used today. Those are the drugs that we use, or through surgery where the testis is removed through a process called orchidectomy. Now, for us to really appreciate the removal or the cessation of the production of androgens, let us just take a quick look into the biology and physiological function of androgens. First, the sex steroids are divided into two: androgen, example testosterone, and then we have estrogen, example estradiol. The androgens are seen as the male hormones, while the estrogens are referred to as the female hormones. As we all know, both male and female have these two sets of hormones, but in different proportion. So in men, testosterone is produced primarily by the testes. And remember, the surgery that we carry out is to remove the testes. So when the testes is removed, androgen is no longer produced. Or if we use drugs, we block the production of androgens. The physiological function of the androgens are as follows. Androgens promote sexual function, muscle development, red blood cell production, positive effect on mood. Estrogen inhibits fat accumulation. Now, both androgens and estrogen have important roles in bone metabolism. As we have seen the function, the physiological function of androgens, at least we can start trying to imagine the issues that are going to come up when the body is deprived of androgen. From this slide, we can see the different function of androgen in the skin, the brain, the bone marrow, the sex organs, the muscles, and the bone. Now, this therapy, is it actually being used? Is it prevalent? According to the research, according to the work by Chibo and others in 2021, published in 2019, published in 2020, it was discovered that ADT is the recommended first-line therapy for advanced prostate adenocarcinoma. What it's trying to say is that even currently, the first-line treatment of advanced prostate cancer is ADT. We have other forms of treatment, but currently, the first-line therapy is ADT. What about in Africa? It's also shown that ADT use is prevalent. Having established the fact that this is what we use both in Africa and other parts of the world, it is good for us to look at the benefits of ADT. One, for men with metastatic prostate cancer, ADT is associated with high rate of response, decreased cancer-related symptoms, and increased survival. For men with high-risk early-stage prostate cancer, we see that the addition of ADT to radiation therapy improves overall survival, whether long-term, 28 to 36 months, or short-term, 4 to 6 months, increase the overall survival rate.
Excuse me, sir. Your
Yes.
Slides are not moving. I'm getting comments that the slides are not moving, and
they are not moving.
They're moving. No, they are not. You are still on the second slide.
Oh, I mean,
it's showing only the second slide, and I'm sure you are about the 6th or 7th slide by now.
Yes. Or will you move it? Will you share it from there? Because I mean, the 6 or 7 slides now.
Okay, CPAN National, is it possible to share the slides?
I sent it to Dr. Rita.
I don't have the copy.
Okay,
So what
can
you do is click on
slideshow?
Okay, I should click on slideshow.
Yeah, click on
Yes.
slideshow.
Okay, let me.
Yes, click on slideshow. At the
Okay,
top
yes.
end, click on, you see, from the beginning,
It's
click on
showing now.
slideshow.
From the beginning. Okay. Can you see the slide now?
Yes, we can see the slide now, but it's showing us slide 10. I think maybe you are probably on like slide 6.
Is it moving now?
No, it's not.
What you do is go to the top, click on slide. Continue to press next.
Can you see it now?
Yes, yeah, we're on physiologic functions of the sex steroids in normal men.
Normal men, you can see it now.
Yes, we can.
Are you seeing it now? I'll move to the next slide.
No, it hasn't moved.
What's wrong with this?
Okay, you can put it on. Yes, it's moving now. The influence of testosterone.
Is it moving?
Length and trends of use
Okay.
of, yes.
Okay, it's moving now. Can I use it like this? Will it be too small?
No, it's okay. It's fine.
Okay.
Thank you very much, sir.
Okay. So we just discussed, we are still talking about the benefits of androgen deprivation therapy. So what we have just said before now, we've discussed the biology of the sex steroids. We talk about how ADT is achieved. Now we are looking at the physiological function. We said it promotes sexual function, muscle development, red blood cell production, mood and cognition. And both of them, both estrogen and androgen, play a big role in bone metabolism. And we have a table showing the different parts of the body where we can see the influence of testosterone, the skin, the brain, the bone marrow, the male sex organs, the muscle, and the bone. The importance of this is for us to visualize what is going to happen when the body is now deprived of these androgens. Now, we said that it has been established that currently the current guideline in the management of advanced prostate cancer is the use of ADT. ADT is the recommended first-line therapy. Unfortunately, in Nigeria, in other Western countries, most people opt for ADT. But in Nigeria, sometimes we usually have a challenge because when patients go for ADT, most people usually prefer drugs to surgery, because when you use drugs, it is reversible. Most of the side effects are reversible. You just discontinue the drugs and you get back yourself. But when you do surgery is used for the very, very advanced cases. But in Nigeria, because of when patients present themselves, most times the clinician have no choice than to do surgery. So now, what are the benefits of ADT? We are told that for men with metastatic prostate cancer, ADT is associated with high rate of response, decreased cancer-related symptoms, and increased survival. Now, before I continue, I want us to understand that there are other methods of managing advanced prostate cancer, but their side effects are very, very severe. So that is why currently ADT is like the therapy of choice. Okay. Also, for men with high risk early stage prostate cancer, the addition of long-term ADT between 28 to 36 months helps to improve the overall survival of the patient. Even when they carry out short-term ADT, 4 to 6 months, added to radiation therapy, it also improves the overall survival of the patient. Also, lifelong adjuvant ADT improves survival in men with node-positive disease after radical prostatectomy. For people that their PSA continue to rise, even after surgery or radiation therapy, ADT is very, very good for such patients. Now, after talking about or looking at the benefit of ADT, what are the adverse effects? We are more concerned about this adverse effects because that is where our management comes in. That is where we are trying to close the care gap. Androgens are physiological anabolic hormones. So therefore, ADTs are accompanied by several adverse effects. As we discussed, when we look at the physiological function of the androgens, say that by depriving the body of this androgen, there are a lot of adverse effects that will come up. However, we are going to look at 5 clinical significant side effects and how we can provide care. First, we want to look at sexuality. ADT causes both erectile dysfunction and decreased libido or sexual interest. Men are often reluctant, as we know generally. Men can be reluctant to discuss their sexual interest with their partner and performance. So you see a lot of men, prostate cancer patients who are undergoing ADT and they're having low libido and they find it difficult to discuss it with their partner. And this may result in withdrawal of both emotional and physical intimacy. And this can be very worrisome, especially if you have a very young, sexually active wife. It can be very difficult. So loss of libido may have an adverse impact on masculine self-image that may already be impaired by reduced penile length, testicular volume, increased body weight, decreased muscle mass and strength, and emotional liability. Let's look at this pictorial presentation. These are the kind of things that usually happen. Hello, am I being heard? Moderator.
So we can hear you. We can hear you.
Yes. Can you see the slide?
Yes, we can see the slide. The pictorial slide. Yes.
These are some of this is the kind of thing that usually happens to people who are undergoing ADT. The libido is low. It can be embarrassing, frustrating, not just for the man, but also the woman. So how can we manage such? When medically appropriate, we should consider shorter treatment duration or intermittent ADT as a strategy to mitigate adverse effects. Remember, we talk about the use of ADT long-term and short-term. So if it is medically appropriate, as a pharmacist, while discussing or trying to develop a care plan for your patients, you can discuss this with the person, discuss with the clinician to mitigate adverse effects. Also, counsel the patient, explain to the patient to improve communication between his partner or partners, as the case may be. An open mind and an optimistic attitude may help improve sexuality during treatment. If it is possible, we can also refer the such patient for professional psychosexual support. Maybe it's maybe neuropsychiatric people may be providing such services. And then at this point in time, injection therapy and vacuum devices. That's what we call a penis enlargement pump. It is preferable to use it to manage erectile dysfunction instead of prescribing the phosphodiesterase inhibitors, the sildenafil, tadalafil, and co. So, in addition, physical activity may also help improve sexual function during ADT. We have another side effect, osteoporosis. Most times when we talk about osteoporosis, our mind naturally goes to women. Most times we think about just women. But osteoporosis is an important but very unappreciated problem in men worldwide. So even though smoking, low dietary calcium, vitamin D deficiency, and sedentary lifestyle can contribute to osteoporosis risk in men, it has also been shown that ADT is associated with greater risks for clinical fractures. Some men, though not all, may develop osteoporosis during ADT. How can it be managed? According to the National Osteoporosis Foundation, the recommendation is as follows. Men aged 50 years and older should be evaluated for osteoporosis risk. Adequate intake of calcium and vitamin D will help the bones. Participation in regular weight bearing and muscle strengthening exercise. Remember, for this exercise, you have to discuss with your clinician. Cessation of tobacco use is very important. Identification and treatment of alcoholism. Sometimes, because of the problem, the low libido, some men give into drinking of alcohol to just calm down themselves. But it even wasn't the problem. So we also have to treat other risk factors for fracture, such as impaired vision. We also have diabetes. Diabetes is another side effect of ADT. And incidentally, ADT increases the risk of diabetes in non-diabetic men with prostate cancer. That is, people who don't have diabetes and they have prostate cancer and are being treated using ADT, there's a risk that they may develop diabetes. There's even greater risk for diabetes as observed with short-term ADT and even long-term ADT. There are greater risks associated with it. And ADT worsens diabetes control because according to Chibo and colleagues, ADT causes insulin resistance. So because of that, diabetes control may become worse. How can it be managed? Well, currently there are no specific evidence-based guidelines to reduce risk of diabetes in men receiving ADT for prostate cancer. However, we can look at the guidelines provided by American Diabetes Association, which states that testing for diabetes should be considered starting at age 45 for all men. Younger men who are overweight and have one or more additional risk factors for diabetes should begin testing sooner. And then men who are at risk for diabetes should be referred to a support program targeting 7% weight loss and increased physical activity. What of anemia? Remember, when we're looking at the physiological function of androgens, see that androgens help in stimulating the synthesis of erythropoietin. We help in the production of red blood cells. So understandably, androgen deprivation will lead to decreased red blood cell production. So what we are trying to say, somebody who has prostate cancer and undergoing ADT, there's likelihood that the person's blood level will be reducing. How do we manage such? Incidentally, some clinicians may not know that this therapy that they are giving to the patient is what is causing the anemia. So they continue sending the person for tests to continue to check. They don't know that it is that therapy that is causing that anemia. So to avoid unnecessary testing, men with prostate cancer and their clinicians should be informed that ADT predictably results in mild to moderate anemia. And then, remember, sometimes we say because androgen stimulates the synthesis of erythropoietin, we remove the androgen and there's anemia. So maybe when we use erythropoietin, on the patient, it will help to stimulate the production of red blood cells. There's something we need to understand here. Treatment with erythropoietin may increase hemoglobin levels in men receiving ADT, but current guidelines recommend against its use because erythropoietin treatment is associated with greater mortality in patients with advanced cancers. So it's not usually used. We don't use erythropoietin to treat anemia in patients undergoing ADT. Now, we have mentioned some side effects. We have mentioned libido, low libido. We have mentioned diabetes. We have mentioned osteoporosis. We have mentioned anemia. Understandably, this side effect and others that have not been mentioned may push somebody into depression. Depression is common in men with prostate cancer and other malignancies, which is associated with higher rates of hospitalization and death. And again, ADT increases feelings of depression, tension, anxiety, fatigue, and irritability. So sometimes maybe people who are going through such, maybe the partner who may not understand exactly what has happened. Maybe you request for something. There may be transferred aggression. The man may just be depressed, may just be depressed and affect other aspects of his life. And again, men with prior history of depression are at greatest risk for diagnosis of depression during ADT. How do we manage such? Men with a past history of depression should be closely monitored and referred to the primary care provider or a mental health provider at the first sign of depression. If anxiety or depression are significant, treatment with an antidepressant may be indicated, and in some cases, prophylactic use might be considered. Sleep disturbance, sometimes related to a nocturnal hot flashes, may worsen depression. Hence, use of an antidepressant may treat both depression and hot flash symptoms. Cognitive behavioral therapy and mindfulness-based stress reduction can be useful adjunct to or substitute for medication. So we have discussed 5 clinically significant side effects of ADT. We have seen certain gaps where we as pharmacists, we can close in terms of educating our patients, in terms of educating the clinicians. What about pharmacists who are interested in research, pharmacists in academia, or other pharmacists who want to go into research? We still have gaps. That is why there are certain questions that we may want to research further because we still don't understand certain things surrounding ADT. For example, what factors influence the severity of treatment-related adverse effects? We can research on that. Do the adverse effects of ADT change over time? This adverse effect we have mentioned, after some time, do they change? We don't have any research work on that. What is the comparative effectiveness for different exercise interventions? We have been mentioning exercise that will help to reduce some of the side effects. But we have different types of exercise. Now, what are their different effectiveness? We can also research on that. What can be done to improve compliance with lifestyle intervention? We've talked about lifestyle intervention, cessation of alcohol, cessation of smoking. How can we help our patients to comply? What can be done to improve compliance? Because most patients don't comply with this lifestyle intervention, we can research on that. What are the roles of complementary medicine and practices to mitigate adverse effects of ADT? Pharmacists who are in that specialty group, they can research on that, complementary medicine. And then, are there biomarkers that can reliably predict risk for adverse effects? So these are knowledge gaps that give way for future research. There are a lot of gaps. So there are a lot of things we can do. We can give direct care. We can go into research to come up with something that will still lead to pharmaceutical care. In summary, we have seen that ADT improves prostate cancer outcome in some settings, but has potential adverse effects. And as pharmacists, we can close certain care gaps in ADT management, thereby improving the overall patient quality of life. What about lifestyle modification? We can counsel our patients on healthy nutrition. If we look at this picture, we see the different colors. Dietitians call it eating the rainbow. Advise them to eat food that has different colors to obtain the different phytochemicals in the plants. So when they increase consumption of vegetables and fruits, including calcium-rich plants. What about healthy habits? Stop tobacco use. Well, the last time we interacted with our patients that have prostate cancer, when they came to obtain the drug, did we discuss with them to stop smoking if they are on tobacco or drink alcohol? Most patients don't know that they have to stop these things. Also, exercise. Exercise, increase physical activity to at least 150 minutes per week of moderate activity, prevent or treat obesity, and reduce risk for diabetes and cardiovascular disease. So exercise may also mitigate some of other adverse effects of ADT, including muscle loss, obesity, sexual dysfunction, and physiological distress. Especially thank all of us for attending and listening to this presentation. I want to thank Clinical Oncology Pharmacists of Nigeria and also Prostate Cancer Foundation. Thank you very much.
Wow. Thank you very much, Pharmacist Oboita. I hope you can all hear me. I think Pharmacist Oboita has done a very good job of recapping. You've made my work very simple, but since I've been asked to do it, I will do it again and correct me if I'm wrong. But what Ita took us through, I think, let me see, I did some notes here. I went away with some major things. One is that provision of pharmaceutical care, regardless of what field we play in the system, we all need to close the care gap as far as cancer is concerned and with our cancer patients. We generally discussed ADT and what it means. It basically means we are trying to improve the quality of life of our patient. That is our primary goal, which is to improve the quality of life of our patient. ADT therapy is used in advanced prostate cancer, and it basically means we are depriving the body of sex hormones either through drugs or through surgery. Am I right? ADT is the first line treatment in advanced prostate cancer. However, in Nigeria, there is a challenge because where the use of drugs or the effect of drugs are reversible, with surgery, it is not. So as pharmacists, we need to concentrate on closing the care gap by helping our patients manage their adverse effects. And we looked at quite a few of the adverse effects, mainly loss of libido, diabetes, anemia. And what I found very interesting with anemia is that erythropoietin is actually contraindicated when in anemia caused by ADT, because what it does is it increases the mortality rate. We also look at depression and how to handle depression with our patients. And then lastly, we looked at the different knowledge gaps and how, as pharmacists in our different fields of pharmacy, we can help to address the knowledge gaps. Now, please, do we have any questions for pharmacist Ita? If we do, you can either drop it in the chat box or just raise your hand, and I would give you the chance to speak. So do we have any questions? Am I muted? No, I'm not muted. Do we have any questions for our presenter today?
Hello, my hand is up.
Ah, thank you very much. Thank you. So Dr. Felicia Williams, please, you have the, I would love to say the floor, but we are not on the floor. So I'll just say you have the mic. Thank you.
Okay, thank you so much, our presenter, for doing a good job. The first question or comment I has to do with ethical issues with the pictures you showed. I was thinking there should have been a way of covering the faces of those patients for ethical reasons. For slides 13 and I think 24 also. Then secondly, do we have food, drug, ADT interactions that you want to enlighten us on? And thirdly, apart from the erythropoietin contraindications, contraindication for ADT, are there other contraindications that we as pharmacists need to look at and advise the clinician and even educate the patient during the use of ADT? Thank you.
Thank you, Dr. Williams. Please.
Okay, can I respond?
Yes, please.
Okay, thank you so much. When I started, I acknowledged the material that we use coming from Prostate Cancer Foundation. The permission of these patients we asked their permission before we use it on these materials. And then also, some of the pictures are purely for illustrative purposes. Then you talked about the interactions, ADT food interaction, ADT drugs interactions. Now, the truth is that currently, there's a lot of research ongoing, because in one of the questions I asked, one of the questions that has to do with the care gaps, they talk about research on adverse effect, what will happen when you continue ADT after some time. The Prostate Cancer Foundation, experts are currently undergoing a lot of research to come up with questions like the one you've asked concerning these interactions. The drugs that we use, Luprolite, and I think they are just basically like two we use now. They have a lot of side effects. The drugs have a lot of side effects. We have other side effects that we did not mention. Now, I cannot authoritatively tell you most of these interactions because researches are still ongoing. Even the materials that we use in making this presentation are part of certain researches that they are carrying on now. That's why I have to acknowledge them. So there's an ongoing research on that. I think a lot of unknown in this area, a lot of unknown. It's just like you start to use a new drug, a lot of things we don't know about. Unlike, say, you are talking about a drug like chloroquine that has been there, you can say, okay, this is the effect, this is the effect. So there are so many things we cannot authoritatively say for now. So that is why I'm somehow silent on that issue. But we believe as time goes on, will come up as the result of these researches come up. It will be presented. And even the questions I've asked are still issues that we are still trying to research on. So that is it.
Thank you very much, Mr. Speaker. Dr. Felicia Williams, I hope that addresses the questions.
Yes, thank you.
Thank you very much. Pharmacist Rita Ukeredi, please go ahead and ask your questions. Thank you.
Okay, good evening, everyone. I hope I'm very audible enough. First and foremost, I want to sincerely apologize for joining in late. I have some network challenges, but I must start by first commending at least the 7 participants that have joined us for today's special edition of our clinical meeting. Yeah, I really appreciate everyone, and I must commend us because it's a whole lot of sacrifice. And I want to sincerely and humbly appeal that we all are great ambassadors of this our association, and we'll do a lot more to help it grow by trying as much as possible on one-on-one basis to invite people for our usual monthly clinical presentation, because it will go a long way to help us grow. Then, secondly, I want to also commend our erudite and eloquent speaker tonight, Pharmacist Ubonita. We really appreciate you for doing justice to the topic, despite the short notice as it were. Then our moderator, you did excellently well by really summarizing it. That's why I joined midway, but with your summary, I was able to catch on some point. Really appreciate you, man. Then also again, I wanted to ask if there were some valuable tools, as you mentioned, care gap per se. If there are some tools that we can use to help easily identify these patients that have these adverse effects of depression while using the ADT therapy, because it's going to help. If we can be able to pick them on time, then we can able to administer the psychotherapy on time and manage them early, and the outcome will improve. So I don't know if there is any standardized tools that we can use as clinical pharmacists. So ultimately we see that we can easily pick them. Then I highlighted some valuable key points that we can look at for research. And it's brought to my mind the issue of the journal club that we also have in other specialty groups like the infectious group. I want us to have it in our minds and think on how we can work on the logistics to actually have one of our own. Then we can look at these various topics you've highlighted, very wonderful research topic. We can actually come together as a family to actually see how maybe it won't be a bad thing to have a journal in the CPAN journal. It will go a long way to help us too. I know there are so many highly respected persons here. I must sincerely appreciate Dr. Felicia Williams. She has been consistent in our clinical meeting and making meaningful contribution. Likewise, others too that have been here. And I know they are into academics and they will go a long way to actually help us in maybe getting 1 or 2 papers published, collaborating with various states that have good things happening in their place to actually even if it's one or two at a time, we can do a pilot study like that to help our group grow and beautify it. So those are the questions/comments I would like to make. Thank you very much, everyone.
Thank you very much, Pharmacist Rita Okerede. Ita, will you?
Yeah. Let me just respond to one of the questions she asked. The issue of whether we have a tool that we can use to identify patients with depression. The truth is that when we start talking about depression, we are actually moving to a very technical aspect. Our expertise as clinical pharmacists is one of the things that will help us to identify whether this person is actually drifting into depression. And then because that is the purpose of patient discussing with your patient. When you identify such, in that slide that talks about depression, it's not about referring such persons to the appropriate care facility, because it's something that we may not be able to handle, a patient that is going through depression. When I was in the community practice, I came across a lot of depressed patients. As at that time, what we usually do is that I work with pharmacists in a neuropsychiatry hospital, Calabar. Sometimes we refer patients from there, they follow it up, hand it over to the clinicians and go, and they take it over from there. So we have to learn how to collaborate, because especially when it comes to the issue of depression, it's not a straightforward something. Sometimes antidepressant may be used, and it may involve the clinician handling the patient's prostate issue. So that's why we need to refer when it comes to that. So we have to collaborate. We collaborate with thank God we have pharmacists, we have a clinical group that has to do with mental health. So we collaborate with ourselves so that when issues like that come up, we refer, and from there, the case can be taken up, and then the person can be managed very well. Because when there is depression, even the drug of the prostate drug, the patient may not comply. So, but I believe as we evolve, we may, with time, come up with a particular tool. But if there is any one I'm not aware of, but for now, I think it's more of our clinical expertise and our ability to refer and collaborate with patients, with pharmacists in such specialty, and they will take it from there.
Okay, thank you very much. Thank you. I guess at this point in time, we're running out of time now. I would like to say a very, very big thank you for all our participants who have come in and stayed right through to the very end. Well, I can't say I mean, it was a very interesting, very educative lecture. So I'm not surprised we have everybody here till the end. I would like to say a special thank you to, again, all our participants, special thank you to our lecturer, special thank you to Dr. Felicia Williams and Pharmacist Rita, who asked these very interesting and educative questions. They've pointed out quite a lot of things that someone like me has overlooked. And again, thank you very much, Pharmacist Oboita. And with this, I say a good night. And please, let's go out there and close the care gap as oncology pharmacists. Thank you very much. And good night.
Thank you. Good night. Mm.
Good night, all.
Good night,
Good
everybody.
night, everyone. Thank you for